Good afternoon and welcome to Cancer Conversations, a program brought to you by UNC Lineberger Comprehensive Cancer Center. My name is Jennifer Potter and I'll be your moderator today. I want to call your attention to the phone number on your screen. If you're having any technical problems, can't hear us, can't see us, please don't hesitate to call 919-445-1000 and we'll be glad to help you. I also want to show you the email address on your screen, the cc@med.unc.edu. This email address is going to be on the bottom of your screen throughout the presentation, and that's where I'd love for you to send any questions you have for our presenter today. We will have some time at the end to address those. So without further ado, I will start today's lecture. We have Mary Dunn with us. She is an adult nurse practitioner here at UNC Chapel Hill. She specializes in urologic oncology and treats patients with renal, testicular, bladder, or prostate cancers. She's very accomplished, but among one of her appointments is director of the Testicular Cancer Survivorship Clinic. Today she's here to speak with us about prostate cancer screening. As you may know, Prostate Cancer Awareness Month is September, so we thought it was only appropriate to invite her here to talk to us about prostate cancer today. So without further ado, I'll turn it over to Mary.
Hi everyone, thank you so much for having me. It's a pleasure to be here with you all on this beautiful Friday afternoon in Chapel Hill. Very much looking forward to speaking to you all about this very important very hot topic about prostate cancer screening. These are just some objectives. So we're going to discuss risk factors for prostate cancer. We're going to discuss the pros and cons and the risks and benefits of screening for prostate cancer. And we're going to review some different strategies that you can talk to your healthcare provider about prostate cancer screening. And when I say healthcare provider throughout the talk, I mean that to reference either your physician, your nurse practitioner, or your physician assistant. So what is prostate cancer? So cancer is a growth of abnormal cells. Prostate cancer starts in the cells of the prostate. So the bladder is here. The prostate sits right underneath the bladder. And what do we know about the prostate? Well, only men have prostates, and it helps secrete the stuff that comes out during ejaculation. It helps make the semen. A healthy prostate is about the size of a walnut, but a large prostate does not necessarily mean an unhealthy prostate. Again, this is just another picture showing where the prostate sits in the pelvis. So this is the bladder. This would be like a side view. This is the bladder. The prostate sits right here. The urethra, which is the tube where the urine comes out, runs through the prostate and down through the penis, and that's where the urine comes out. How common is prostate cancer? Well, prostate cancer is very common. Other than skin cancer, it's the most commonly diagnosed cancer in men in the United States. There are nearly 3 million men who are living with prostate cancer. And men have a 1 in 9 lifetime risk of being diagnosed with prostate cancer. It is the second leading cause of cancer death in men, and this year there'll be about 175,000 new cases diagnosed across the country. What these graphs and charts show is that the majority of prostate cancers, when they're found, when they're diagnosed, are localized. And what I mean by localized is that it's confined to the prostate and it hasn't moved outside of the prostate gland. What causes prostate cancer? Well, unfortunately, we don't know the exact cause. We think that it's most likely related to changes in the DNA of the cells in the prostate. DNA changes can happen in several ways. So it can happen from environmental exposures, it can be passed down through families, and a lot of times we just don't know why these changes happen within the cells. What are some risk factors? What we know about prostate cancer is that the majority of patients who are diagnosed with prostate cancer are older, so 65 years or older. We know that African American men have the highest incidence and death rates from prostate cancer. We also know that men who have a first-degree relative who has had prostate cancer have themselves a twofold risk of being diagnosed with prostate cancer. There have been a lot of research studies done on diets and supplements to see if there are things that we can avoid so that we don't develop prostate cancer. Unfortunately, there's no clear data that show that particular dietary intake or supplements are a direct risk factor for developing prostate cancer. Other things that have been studied extensively are obesity, not being active, exposure to certain chemicals, sexually transmitted infections, and vasectomy have been studied to see if there's a link between these things and the risk of developing prostate cancer, and there's little or no evidence to show that those things increase one's risk for being diagnosed with prostate cancer. Can we prevent prostate cancer? Well, it's a little tricky since we don't know the exact cause of prostate cancer. It's not possible to prevent most cases of the disease. We can't control how old we are, we can't control our race, we can't control our family history, so the things that our parents pass down to us in our genetics. So what can we do? I certainly don't mean to sound hopeless. What we do know is that things that are heart healthy are also prostate healthy. So maintaining a healthy lifestyle, in other words, a balanced diet, making sure you're getting in those fruits and vegetables, lean meats, proteins, and whole grains, regular cardiovascular exercise, try to avoid using tobacco products, and minimal alcohol. So even if the data for prostate cancer specific prevention tools are limited, we like to encourage these things to promote your overall health and well-being. Screening. When you hear the word screening nowadays, you might be thinking about these types of screens because we are all constantly having our face, at least I am, buried in some sort of screen. But screening is a tool to check for a disease. You may have heard some of the debate about whether or not we should be screening for prostate cancer. I'm going to go into a little bit of that debate because I think it's really important to talk about and to dispel some of those myths that you may have seen or read about in the media over the past few years. One of the biggest points in the debate is, are we over-screening? In other words, are we screening people who may not need to be screened, which might lead to overdiagnosis and overtreatment of a cancer that may not affect a person throughout his life? So like I said, screening is a test to find cancer before symptoms occur. Screening for prostate cancer has been widely and hotly debated over the past, 5+ years at least, since some different recommendations have come out. There are many professional organizations who have issued their recommendations for screening. The only real agreement between these organizations is that men should be presented with the benefit and risk of prostate cancer screening and have a thoughtful discussion with his healthcare provider about if it's the right thing for him to do. So, how do we screen for prostate cancer? We do a prostate exam called a digital rectal exam, and that's when we insert a gloved and lubricated finger into the bottom to feel the prostate gland. What we're feeling, therefore, are several things, but the most important thing is to make sure that the prostate is smooth. In other words, the prostate shouldn't have a lump or a bump. It should be nice and smooth. It should be mobile. It should be non-tender. We can also get a basic idea of what the prostate size is when we do that exam as well. There's also a blood test that's done to screen for prostate cancer, and that's called PSA. PSA stands for prostate-specific antigen. PSA is a protein that's made by the prostate. The prostate gland itself is full of PSA, and it kind of leaches it out into the bloodstream, and that's how we check it with the blood test. PSA has been around since about the late 80s or early 90s. So neither the prostate exam nor the PSA blood test is 100% accurate. So abnormal results don't always mean cancer, And normal results don't always mean absence of cancer. So you can see where some of this can be a little bit confusing. There are other tools that are in development right now that researchers are trying to figure out, can we use them along with the prostate exam and the PSA to screen for prostate cancer, or someday will there be something to replace either one or both of those screening tests? Other tools that are in development are things like prostate MRI, which is a fancy type of X-ray, biomarkers, which are fancy blood tests that are put out by companies to see if we can help determine who to biopsy to check for prostate cancer. And then there are prostate cancer risk calculators, which you can actually find online. These are tools that have been validated. I use them in the clinic to type in information about my patient who's there in front of me. It usually includes questions about age and race, family history, PSA, how the prostate feels, and prior prostate biopsy. And then the calculator spits out percentages of, if we were to move forward with a biopsy, what's the likelihood that based on this person's individual characteristics that he may have prostate cancer. So what's the big deal when it comes to talking about PSA? Well, I know this is a busy slide, but I really wanted to point out the reason why PSA is such an imperfect test. It's mainly because there are a lot of different things that can affect the PSA. So just because the PSA is abnormal does not equal cancer. Common things that can affect the PSA blood test are things like prostate infection or bladder infection. So it's important to rule those things out if a man comes in with an elevated PSA. That's an easy thing to do. We can check a urine test. It could be a lab error, so sometimes it's a good idea to double check or validate the PSA by checking it again. It could be inflammation, so some men have chronic inflammation in the prostate that makes their PSA higher than normal. Urinary retention means not getting all the urine out of the bladder. So if men are walking around with a bladder full of urine that they're not emptying all the way, that can lead to an abnormal PSA. BPH just means big prostate, so prostate size can also affect PSA. Instrumentation means if someone has just had a catheter put in through their penis to drain the bladder, that can make the PSA go high as well. There can be age-related changes, abnormal cells that are not cancer cells but also don't look quite like normal prostate, and then of course prostate cancer is on the list as well. And this is not an exhaustive list. These are just some of the things that can affect PSA. There are also certain things that can make the PSA go down. There are certain medications, and of course if a man has been treated for prostate cancer, the PSA can be low. Things that haven't really been proven or don't have a lot of robust science to say, hey, this is definitely the cause of this PSA being abnormal, are things like ejaculating, vigorous exercise on a bicycle, or when we do the prostate exam with our finger. That doesn't raise the PSA significantly enough to warrant much further investigation. So what is all the fuss about? A test that checks for cancer should be a no-brainer, right? Well, not so fast, says the sloth. Who makes these screening recommendations anyway? Well, there's a lot of organizations who have weighed in on the topic of prostate cancer screening. You all may or may not be familiar with an organization called the U.S. Preventative Services Task Force, which is also quite a mouthful, USPSTF. So in 2012, they came out with a recommendation against prostate cancer screening for everyone. And the way that they graded that was with a grade D. This was something that was all over the news in different types of media. They came out with this recommendation based on a big research study that had been done called the Prostate, Lung, Colorectal, and Ovarian Cancer Trial, also called the PLCO trial. Several years later, this organization changed their recommendation from a grade D, which means don't check a PSA on anyone, to a grade C. Why did they make this recommendation? Well, because the recommendation in 2012, unfortunately, was based on flawed information from that very large research study. It was found that 80, honestly, even closer to 90% of the men in the control arm, in other words, the arm of the clinical research trial where the participants should not have been having PSA screening, had actually been having PSA screening. So we think that this trial was probably significantly contaminated based on this new information. So what does the grade C recommendation from this organization mean? Quote, physicians should offer or provide the service for selected patients depending on individual circumstances. In this case, their recommendation was for men aged 55 through 69. So the American Urological Association is a large association for urology providers. They also have their own set of recommendations for PSA and prostate cancer screening, as do several other organizations. I'm not going to go through all the nuances of each one of their recommendations, but I just wanted to present this information to know that there are several recommendations out there. I'm sure many of you have heard of the American Cancer Society. They also have their own recommendations as far as who should be screened for prostate cancer, how often, and at what age and interval. So what do? This is an actual cartoon depiction of me. No, I'm just kidding. But it feels that way. This can be a lot of information. It can be confusing for a lot of people. And at the end of the day, it's my job when I'm seeing patients in clinic to make sure that each patient has all the information that they need to make an informed decision about whether or not they should be screened for prostate cancer and what to do if we find an abnormal PSA. And this takes time. What is at the heart of this debate? So there's a question of really anything in healthcare is are we doing more harm than good? When we check PSAs, are screening causing more harm than they are for the greater good? There's concern about overdiagnosis, and that means finding a prostate cancer that we would consider low risk or very low risk in men who would never have had symptoms of the cancer in their lifetime and never would have been affected by it. And the treatment of men who would not have had symptoms or died from prostate cancer, but can have significant complications from treatment, but no real long-term benefit of the treatment, meaning that if we had left everything alone, they never would have been affected by it in their lifetime. So I wanted to go through some pros and cons of prostate cancer screening with you. So one pro is that PSA screening may help you detect prostate cancer early. And it is really important to identify serious prostate cancers in an early stage. On the flip side of that, some prostate cancers are slow growing, never spread beyond the prostate, and are never harmful. Another pro is that there are other tests that are needed to diagnose prostate cancer. Prostate biopsy is a routine thing done by urologists. This is not an obscure test. The downside to doing a prostate biopsy is that there are potential risks that come along with doing that procedure, such as pain, there's risk for infection, and there's risk for bleeding. Also, a prostate biopsy may miss a prostate cancer diagnosis. What I mean by that is that a prostate biopsy is simply a snapshot of what's going on. So we usually follow a 12-cord template where we take 12 small pieces of the prostate and send them off to be looked at underneath the microscope. So there's a chance that we may not hit a certain part of the prostate that's harboring prostate cancer cells. Cancer is much easier to treat and is more likely to be cured if it's found in an early stage. Not all prostate cancers need treatment. Treatment may have some side effects like leaking of urine, sexual problems, and bowel problems. PSA testing is pretty simple as long as you bring your good veins with you to the appointment. It's widely available and it costs around $8 depending on the lab that's used. As I've talked about, PSA is an imperfect test. It could be high or above the normal range when cancer is not present. That would be what we call a false positive. And it could be normal when cancer is present, meaning a false negative. This is a very, very, very common thing and very understandable. For a lot of men, knowing is better than not knowing, and that's very understandable. Having this test can bring people peace of mind. Either that you probably don't have prostate cancer or that you may have it and we need to move forward with further testing like a biopsy. A diagnosis of prostate cancer can cause some anxiety and it can cause some confusion too. There can be concern that the cancer may not be life-threatening and can make decision-making hard. Living with a slow-growing prostate cancer that doesn't need treatment can also be really stressful. A lot of men, when they are diagnosed with prostate cancer, if it's found at an early stage, are candidates for several different treatment options. And we talk to folks about those in great detail, but it's not always easy to make the decision about what's best for you given that there are multiple treatment options. The number of deaths from prostate cancer has gone down since PSA testing has become widely available. That is certainly a good thing. PSA testing has lowered deaths, but the number may not be significant enough to justify the cost and possible harm to the person undergoing the test, like stress, worry, anxiety, potential complications of biopsy, and potential complications of treatment. Like I mentioned, there are multiple treatment options for men when they are diagnosed with early stage prostate cancer. Now, some men may not be eligible for all of these, and some may. So there's active surveillance, which is a regimen where we watch people. We do repeat biopsies periodically, and we follow the PSA numbers and not immediately jump into a treatment. There's surgery to remove the entire prostate. There's a couple different types of radiation therapy. So there's external radiation. There's internal radiation with brachytherapy seeds that are put into the prostate. There's cryotherapy, which is freezing of the prostate, and something called HIFU, which is ablating the prostate. So lots of options. For advanced stage prostate cancers, meaning prostate cancers that may have gotten outside of the prostate, there's hormone therapies, chemotherapies, there's very strong pills that men can take, there's one immunotherapy available, and there's a radiotherapy that's available. I think one of the most important things that I want you all to remember is that it is very important for you to feel empowered when you're talking to your healthcare provider. So your primary care physician, your nurse practitioner, your physician assistant. And ask questions about PSA screening and if it's right for you. So what is my chance of getting prostate cancer? Ask that person, do you recommend that I get screened for prostate cancer? Why or why not? If my PSA is outside of the normal range for someone of my age, what's the next step there? If my PSA happens to be normal, do I need to have it checked again? And if so, how often? Screening doesn't lower the risk of having prostate cancer. It does increase the chance you'll find out if you have it. That PSA blood test can detect early stage cancers that a prostate exam can miss. So when we are doing the prostate exam, we can only feel the back part of the prostate gland. We can't reach around and feel the front part. So the prostate exam itself is also not a perfect test. A normal PSA doesn't mean that you don't have cancer, and an abnormal PSA doesn't mean that you do. A high PSA number may lead to further testing that has potential side effects, and also may lead to finding out that you might have prostate cancer, and then we have to have a very thoughtful discussion about what do we do with that information depending on what those cancer cells look like underneath the microscope. And as that very busy slide showed, many, many things can elevate and affect that PSA blood test number. So some final thoughts. This is not a one-size-fits-all. The recommendations for you may not be the same as the recommendations for your friend, coworker, or neighbor. This should be a very individualized and thoughtful discussion between you and your healthcare provider. We need better research. We need longer-term trials to really assess the benefits and harms of prostate cancer screening, so we as healthcare providers can continue to make the best recommendations for our patients. We also need other tools. We know that this PSA number is imperfect, but quite honestly, it's the best we got. So hopefully one day in the future we'll have tools that can help along with PSA, or maybe someday even replace it as a screening tool. So whether or not PSA actually saves lives is not exactly black and white. It can certainly reduce the risk of dying of prostate cancer, but there's no evidence that it actually reduces the risk of dying from anything else. I really enjoyed being able to present this information to you. I know it's a lot, and I'm more than happy to take any questions about PSA and prostate cancer screening, and sincerely thank you for your attention.
Thank you so much, Mary. That was great.
Thank you.
Everyone who's watching, I just want to remind you of that email address. We have had some questions come in, but we certainly have time for some more. And that email address is cc@med.unc.edu. So one of the questions that came in, Mary, was about signs and symptoms of prostate cancer. Would you mind addressing that a little bit?
Yeah, that's an excellent question. So the vast majority of prostate cancers have absolutely no symptoms. Since we are diagnosing many prostate cancers in an early stage, men don't present with symptoms. A lot of times, as men get older, the prostate can get larger, and that can present as symptoms of just big prostate, urgency, frequency, getting up more frequently at night to urinate, slow stream. But that's not necessarily a red flag for prostate cancer. That could just be for BPH and big prostate. For men who present with more advanced prostate cancers, in other words, prostate cancers that actually have big tumors in the prostate, or unfortunately, if they are caught at a late stage and are outside of the prostate, that can present with things like really bad urine symptoms, not being able to void at all, or bone pain and those types of things. It's a great question.
Great. Thank you so much. Another question was about family history and better understanding what a first-degree relative is and a second degree and that kind of thing, and helping that inform your decision to be screened.
Absolutely. So this is one of the major reasons why when you go and see your healthcare provider, if it's the first time meeting you, they take a very detailed family history, because we can get a lot of clues from a family medical history. So what's important when talking to men about whether or not that they may have an increased risk of prostate cancer is if they had grandfather, father, or brother who has had prostate cancer.
Okay, wonderful. And then lastly, is there anything about genetic testing? You know, we see everything on TV advertising 23andMe and those types of things, and this question has to do with have tests been developed yet to screen for prostate cancer with using your DNA?
You guys are just full of great questions. Thank you so much for all these wonderful questions. I'm not a genetics expert by any stretch of the imagination, but what I will tell you is another part of that family history is not only asking people for prostate cancer family history, but other cancers in your family, particularly breast cancer and any female relatives. What we know about more advanced prostate cancers is that people who have certain genetic mutations, you may have heard about BRCA1 or BRCA2 in the breast cancer setting. We know that there are some men who also harbor those mutations and some others. So what we're doing here at UNC is for men who have more advanced prostate cancers, so prostate cancers that are outside of the prostate already, we're having our genetics team meet with them to talk about the pros and cons of doing genetic testing through a blood test to see if they harbor any specific genetic mutations that we could then target with future treatments. Now, about all the things you see on TV with the 23andMe, I think it's the Ancestry and those types of things, those tests are not as detailed and specific as what a blood test with a genetics specialist could offer. So if you have any more questions about that, talk to your primary care provider about whether or not you should have a consult with a genetics professional.
Okay. And I think we have time for one more. This question is about better understanding the use of x-rays and MRIs and how that could be used I guess to better see the prostate and to make a diagnosis. Can you talk a little bit about that?
Absolutely. So there is a tool we have in our toolbox that we've been using for the past couple of years. It's an MRI that takes very detailed, fancy pictures of the pelvis, specifically focusing on the prostate. Now, an MRI is a magnet. You go into a tube and it's very loud and a little bit enclosed. The scenarios in which we're using that now are a couple. So number one, men who have had a prostate biopsy already that was negative, in other words, didn't find any prostate cancer cells, but have a persistently rising or abnormal PSA, we can use an MRI to say, hey, is there something that ultrasound during the biopsy on the other side of the prostate may have missed that we can then target with a fancier kind of biopsy. The second scenario is men who have already been diagnosed with prostate cancer who are on a surveillance protocol. We use MRI on occasion to take those pictures and see if there's anything that looks suspicious in the prostate that on future biopsies we can then target. There has been a recent paper that came out in the New England Journal of Medicine, which you all may have heard about doing MRIs up front. And what I mean by up front is for men who have yet to have a prostate biopsy but have an abnormal PSA, and doing an MRI to say, hey, does the prostate look pretty healthy or is there something suspicious? And then helping guide us with the next step. We're pretty excited about the prospect of being able to do that for men. Unfortunately, the problem we're running into with doing MRIs before biopsy based on high PSA alone is that a lot of insurance companies are denying them right now. So even with this paper that's been published that shows the advantage of that, a lot of times insurance companies are late to kind of catch up to the data and research. But we're really hoping in the future we'll be able to offer that as an upfront tool. It's a great question.
Great. Well, thank you all for submitting your questions. I hope that was helpful. And if anything comes to mind later in the day, feel free to email that address and we'll take care of your question. I wanted to tell you very briefly about our session next month where we'll be talking about living well with breast cancer. So a little bit less about prevention and early diagnosis and more about living as a survivor or as someone with breast cancer as a chronic disease. That'll be on Friday, October 25th, and we'll be starting at 12 o'clock. So again, thank you so much, Mary. It was wonderful to have you. I appreciate your time.
Absolutely.
And thank you all for tuning in today, and we will see you next time. Thank you.